admitted to the local hospital, Cần City, with the diagnosis very high risk non-STEMI, and the interventionist, he is the young fellow from were trained from my center, called me for a referral. Triple vessel disease with the Leftman disease. And the patient very old, he refused bypass surgery. And so he referred the patient to our cath lab. Medication, enoxaparin, aspirin, clopidogrel, atorvastatin, bisoprolol, nitrate. It's easily not special finding QY in the inferior area. Laboratory examination, we have the cardiac enzyme high sensitivity troponin increase very high, and pro-PNB increase very high, but the echography ejection fraction is so on. And before the patient come to our hospital, I receive the coronary angiogram from provincial cath lab. And you see CTO in the right coronary artery. And we can see the very calcified in the lab. And in the lab, you can see very calcified with large burden in the distal Leftman involved to the ostium of pole of LAD and circumflex. And one thing more, very important thing, we can see one aneurysm in the mid LAD, in very calcified and very stenosis in this area. You can see here. Yeah, we can see the aneurysm. So what can I do? I think it's the special situation. Dr. Kwan Lee can give more. So the first, we do the interpretation of the coronary angiogram. Last remaining vessel is mean CTO in ostium right coronary artery. Heavily calcified distal Leftman involved pole of ostium of LAD and circumflex. Heavily long calcification along distal Leftman osteoproximal mid LAD, and particularly in combination with an aneurysm in severe stenotic calcified segment in the mid LAD. It really very difficult complex case of very elderly 91 year, and he refused the operation for a long time. And I think it's very naturally and or reasonable if I can get the DA 90-year-old. One day some young interventionist come to meet me and ask me to operation. I refuse. Yeah, I think it's naturally. So can we do that? Can we do something? If yes, how can we do that? We very familiar with the algorithm, the very severe, so we must atherectomy. And by now, as you know, we have some selection criteria. It's the this difficult lesion, moderate difficult lesion, and most difficult lesion. This patient belongs to the most difficult lesion, long calcified. I think at least 30 millimeter, heavily calcified, significant, and so on. And one more, the complexity of the bifurcation PCI depends not only on anatomy of the bifurcation itself, but also on the whole of coronary artery tree. And we have a phenotypic classification of complex bifurcation. The two bifurcations were defined as important localization. You can see the lower important localization of the bifurcation. It means the distal Leftman or some position supply in for a large amount of myocardium, and plot with red the following. 1. Heavily calcified bifurcation such as this case. 2. Sequential tandem bifurcation, it means a 2 or 3 bifurcation sequential. 3. Critical stenosis lesion nearby. 4. Triple vessel disease, such as this case, triple vessel disease. 5. Small diffuse disease, as you see, diffuse and calcified tortured LAD. Thrombus containing lesion maybe because the distribution are non-STEMI. Bit revascularization, no, this case. But large remaining vessel in this case because CTO in the right coronary artery disease. Trifurcation and quadrifurcation, no. So I think this case very complex bifurcation. And according to 2020 SKY consensus or complex bifurcation PCI, it means anatomy, comorbidity, and we need equipment. How about equipment in Vietnam by now for complex bifurcation? Intravascular imaging, intracoronary physiology, FFR, IFR, guide catheter extension, a special coronary wire, special balloon, cover stand, atherectomy, rotablator, OAS, lithotripsy, embolic protection device, and mechanical circulated support. In Vietnam, we have IVUS, we have OCT, we have FFR, we have IFR, we have the microcat, we have a special coronary wire, special balloons, cover stand. We have a rotablator only. And we have a filter wire, we have a balloon pump, we have an ECMO. And what can we use this tool in my patient? Plan to do the PCI with a strategy. The first patient have a heavily long calcified with large burden along this development to the LED. Should we use the cutting balloon or scoring balloon or rotablator in Vietnam? The second, heavily calcified distal ligament involved pole of ostium of the LED and circumference. So we must stenting distal ligament, provisional stenting side run technique or intentional true stent technique. The third, in combination with an aneurysm of severe stenosis calcified segment in the mid-LED. So aneurysm is the contraindication for atherectomy of balloon dilatation. So what we can do? We do occluding aneurysm. If we do with the technique being done first, or we do separately stage PCI or simultaneously, it means we do calcified lesion in the same time with the occluding aneurysm. And the patient large remaining vessel, CTO of ostium RCA, do we need mechanical cardiac support? I like to hear some advice and some comment from panelists. My presentation have 20 minutes and with 10 minutes for discussion. Can you give me some advice?
Yeah, so Professor Young, that is a fantastic, extremely challenging case. I think it would be extremely challenging for whether it's US or Vietnam. So congratulations for taking it on. I think if this was done in the United States at my center, we would definitely do this with mechanical circulatory support. There's just too much at risk. Especially if you only have a rotablator and there's a risk of no reflow and dissection, there's just nothing to bail you out. So we would either do that on impeller support or we would do it with ECMO. I did exactly a case like that, 91 years old as well, but we did it with ECMO, and we used orbital atherectomy along both lines. Definitely, we would use IVUS to pre-plan our case and to understand exactly where we would place our stents. I would definitely not try and do the mid LAD at the same time. I think it's much more important to reestablish flow into the left main, stabilize the patients, and then it give you a lot of options to come back later. One thought is to actually start with the CTO of the RCA. If the CTO is crossable and you can revascularize the RCA, you immediately make the procedure a lot safer. Clearly, you don't want to try too long, but sometimes, you know, as we all know, there is going to be no harm to try. As we all know, if you start off that way and you get across, then you are in a much better place when you're working on the left main LAD. I think I would probably use IVUS to understand whether I need to rotor blade into just one branch or both branches. I think that's an important statement. If you do it without revascularizing the RCA, you obviously want to do it as fast as possible. So some of the techniques like DK crush, which tend to take a bit longer, may not be the best technique to use if you want to go very quickly. And you might want to use a provisional stenting technique, pick the best branch, and then use a tap as bailout or a culotte as a bailout if it doesn't work very well. Yeah, I think that's generally, and in the US, if I can help it, one of the strengths of having a lithotripsy balloon is that you don't have a risk of no reflow or embolization. So I did a case quite similar to that the other day, but I used lithotripsy in both branches instead of using rotoblader, and we were able to get away without having to use mechanical circuitry support. You know, so yeah, and I look forward to the thoughts of my other colleagues. Thank you.
Okay, thank you so much, Dr. Kwan Lee. By now we have just only IVUS, OCT, rotablator.
Yeah, Dr. Kumar.
Yeah.
Yeah, Dr. Kumar looks like he wants to say something.
Dr. Kumar.
Professor Ho, this is a very, very difficult and challenging case that you are proposing to the panel. I think definitely in the United States, I agree with my colleague, Dr. Lee. We will definitely do this with mechanical circulatory support at our center. I also agree. In fact, I think we have a fairly similar case to this coming pretty soon as well. Without the aneurysm, of course. The aneurysm always adds another measure of complexity to your case. I think it is reasonable to try and see if we can cross the RCA CTO. If you're able to cross the RCA CTO, especially if you can cross it just antegrade, that would be beautiful, because that would decrease the mass of myocardium at risk. And you may be able to subsequently consider the rest of it without MCS. That could be a reasonable strategy. Or you could say, okay, you know what, I'm going to use mechanical circulatory support with Impella or ECMO, as you may have, and say, okay, I'm going to go for the left main LAD first. I'm going to wire both, rotor both, stent both, secure that left main. I agree with Dr. Lee that the more intensive techniques, such as performing DK crush in that left main, or even culotte with multiple rewirings, is going to be problematic. We tend to prefer a modified mini crush technique in this kind of scenario, with stent in the main branch position, stent in the side branch ready to go, and deploy the side branch stent, pull back the balloon and the wire, deploy the main branch stent immediately. Followed by rewiring, kissing, etc., to kind of expedite this and potentially decrease the risk for destabilization of the patient while this is going on. It's important that we do rapid PCI, because even with mechanical circulatory support, that doesn't mean that the patient cannot destabilize, and we've seen that sometimes as well. Thank you.
Thank you, Dr. Kumar. Maybe some comment.
So I think given the limitations of what equipment you have in Vietnam, I think what I saw that you have ECMO support, you have rotoblader, and you have all these stents, balloons, and the wires. I think I'm going to sort of differ with my colleagues. And I think since you have an ECMO support, you can take your time and you can actually do both the left main LAD circ lesions and then also finish up the mid LAD lesion. Coronary aneurysms, they do not rupture, so I won't even worry about the coronary aneurysm. I will stent across it and hope for the best that I don't jail any other branches there. I would not use covered stent for those coronary aneurysms. So that would be my sort of approach. And I think if I have to rotablate, I will use a 175 burr. I'll make sure that I rotablate the left main, I rotablate the LAD nicely to get a good expansion on my stents. And I just have to have another look at the circ. If there is a tight disease, I may do a rotablate first, the circ, and then go into the LAD and do the rotablation of left main LAD. So I have my wire there in the end, and then wire the circ later on. So that would be my strategy. And with ECMO, I think you have support. You can take your time and finish the patient. I think ECMO gives you that much liberty to it.
Okay, thank you so much, Dr. Rajesh. Different opinion. Yes, this is my strategy, my plan to do PCI. First, I open distal Leftman with post-proximal segment of LD and circumflex, but not include segment with aneurysm. And the next step, if everything okay, I go to open the segment with occluding the aneurysm. We will require Dr. Rajesh suggest a cover stent. And when I perform, and I don't open from the right coronary artery because very high level of troponin and high antiprotein B, and when we can see from the OCT to the retrograde collateral, it's a long way. So we go to do the distal Leftman first. So this is some slide I present my case. The first BCI, I have a plan to do the BCI to the distal Leftman to open for the left coronary artery. You see, very severe and tortuous and calcified along the proximal Leftman to the mid, proximal LD to the mid LD. I wiring difficult. Wiring very difficult. And when I wiring successfully, I use the small balloon 1.7, 1.25, and 1.5 short balloon to open to exchange the rotor wire. But when I exchange the rotor wire, the microcat cannot cross the mid segment of LED because it's very calcified and very strict stenotic. So I must go directly wiring rotor wire through the microcat, go to the distal LED. And by now, I do rotablator with the small burr because I'm afraid it's something. And I rotor apply distal Leftman ostium proximal segment of LED and stop before the mid segment with the aneurysm. I think it's better. And with the strategy, the first I choose maybe I try to keep the regional stenting side branch technique, but when we do the rotor blader and we dilatation with the balloon, the ostium of the circumflex not unstable. So I must do two stent technique with decay cross. Some dilatation of distal Leftman is okay, no problem. Stenting to the circumflex first. After we do the decay cross technique successfully, we have a stent regret. As you see in the proximal of LED, the stent cannot under expansion before the curve. How we can manage stent regress? We use the balloon 3.0 at 3.12 inflate with the atmosphere 24, 26, and the last is open. Kiss the balloon again. Manage stent regress. You can see stent regress very clearly. 3.0, 3.5, 8 or 12 millimeter. So we have the final result of the first PCI, I think, very successfully. The patient feel better. And the aneurysm of mid-segment of the LED stable. So 6 days later, I asked one neurological interventionist help me to coiling the aneurysm. You can see we try to coiling. Rather difficult. After 2 or 3 attempts, we can coiling successfully. After coiling, we have confidence to dilatation of the mid-segment. Preparing for stenting. We must use the extension catheter to bring the stent to this area. You can see Hidezilla. Yes.
The final.
POT, and BOT. And successfully final result. So I think this is a special situation, Dr. Kwali, give more your presentation.
Professor,
in combination with aneurysm.
Yeah, that is more than special.
We have IVUS, we have OCT, but we cannot recall it because very severe. After we stand in the OCT catheter, we don't have it, so we use IVUS. The IVUS cannot go. So the take-home message I have after this case, coronary artery of the elderly, often very severe, diffuse tortuous, calcified, particularly type C, bifurcation, Leftman, triple vesicle G, or CTO. PCI in elderly require advanced techniques and assistance with the instrument, right tone. Revascularization in the elderly should be modified. In the case challenge Leftman case, many stage PCI, it means you can do 2 times or 3 times, particularly at very high procedure risk. Aneurysm in association with the calcified lesion is very difficult lesion. Atherectomy is associated with occluding aneurysm can be considered, but I have only one case, so I can give the conclusion. Thank you so much for your listening.
Thank you, Professor Young. That was really spectacular. And I noticed that you did it without either a IBP or ECMO.
Yeah, I have a balloon pump in heart, but we don't give inside because we give only one vascular asset in the right femoral artery. But in this case, after we have the right asset in the femoral artery, the femoral and the iliac artery dissipation very tortuous. We cannot use in the right. We must go to in the left to do PCI. So I don't know if something happened. I have no asset to go to give a balloon pump.
Yeah. Yes.
A little bit high risk. Yeah.
If you would like to do the mechanical circulatory support, you need the VA or the impeller only, because the patient is very old, the tortoise, the arteries, so difficult for you to push the IBB, and sometimes dangerous for the patient. Yes.
Yeah.
I think that we should try to do RCA first because maybe it's the PCS situation. We have a collateral from the left to the right, but sometimes maybe at first very severe stenosis at the RCA. Now it total occludes. We need to try to do RCA first. If we fail, we come back to the left. It's maybe safer than we directly go to PCI for the left.
Yeah. Okay.
Okay. Thank you.
I agree with you. I would like to ask you one question about that. Is it the aneurysm in the mid LAD? Is need or no need to coil the aneurysm or not? Because the coronary aneurysm maybe last longer, no effect any for the patient. Yes, but sometimes we can use the stand. We can stand. After we stand, in my opinion, my experience, in this case like that, after that we deploy the stand. After stand, maybe sometimes, most of the case, the aneurysm disappear.
Yes.
Yes, I think so. I think because the first we must manage the region, because in this region a very calcified and very severe stenosis in the mid segment of LAD. And I'm afraid if you use the cover stand very, very hot, and you very difficult to give that, given this very stenosis region, you must dilatation. If you do the dilatation, it rupture because aneurysm large. I think so. So we must coil first. After we coil successfully, I have a confidence to continue to do open.
Yes, thank you.
Yes. I want to have a comment, a question for Dr. Kumar. I think with aneurysm, we worry about the thrombus in the aneurysm, formation thrombus in aneurysm. We don't worry so much about the rupture of aneurysm. So in this case, maybe we don't need to coiling the aneurysm. How about your opinion?
Yeah, these aneurysms are complicated. In our experience, I have probably done probably about 8 to 10 PCIs on coronary arteries that have had aneurysms in my career. Because we, at our hospital, we have this Veterans Administration hospital. A lot of our patients belong to the older generation. So atherosclerotic aneurysms tend to be more common. To answer your question, we have not felt that thrombus there was a major issue, especially for a small aneurysm like this. Thrombus is a bigger issue if the aneurysm is larger. Rupture, we're not very concerned. I have done rotational atherectomy past these aneurysms. Fortunately, given the fact that if it is saccular, you're in the main vessel and you're actually quite far away from it and stent across it with relative impunity.
Thank you.
Okay, that was a great discussion. I think in the interest of time, we need to move on to the next lecture. Fascinating case. Thank you for sharing, and thank you for all the expert opinion. Well, many different ways to approach that one. So the next speaker we have today is Dr. Vu Hoang Vu. Hopefully I've pronounced that correctly. Unfortunately, I haven't learned Vietnamese despite having gone there for many years. He's currently the director of Interventional Cardiology Department at University Medical Center in Ho Chi Minh City, and is a member of faculty at the University of Pharmacy and Medicine at Ho Chi Minh City in Vietnam. And he will be speaking to us today about IVUS in optimal PCI for calcified lesions. We look forward to his talk. Thank you.
So thank you, Wan Lee. Today my lecture about the IVUS guidance for calcified lesion PCI. So this is the algorithm for the calcified lesion by euro intervention. When we see the angiographic calcification, if it is mild, we just use a balloon. For example, scoring balloon or cutting balloon is enough for the optimize the result of stenting. But if we see the angiographic calcification by the angiography, if the calcified is moderate or even severe or calcified nodal, we have to check the intravascular imaging, for example, IVUS and OCT to assess the calcified segment. If the calcium arc is more than 270, maybe we need to use the special device, for example, rotablation or orbital atherectomy to prepare the lesion well before stenting. And finally, after stenting, we use IVUS and OCT to check the result, is it optimal or not. So the second slide is about the American approach for the lesion with a high calcium on coronary angiography. I think it's a little different from the Euro intervention. First one, they do the balloon crossability. If the balloon cannot cross, with the balloon, we try to use a microcatheter. And if the microcatheter can cross the lesion, we try to use a rotational atherectomy or orbital atherectomy. And after that, we use a balloon for optimal expansion before the stenting. And if the balloon cannot cross, if the microcatheter cannot cross the lesion, we have to use the direct wiring for the lesion. For example, the case of Professor Dũng, we use the rotor wire directly into the distal vessel of the LED. And after that, we try to use some special device to open the vessel. And if the lesion that balloon crossability is possible, we use a pre-dilatation with a small balloon. And after that, we check the IVUS OCT, and we see the calcium arc, is it over 180 degrees, or the calcium length is it longer than 5 mm, or the calcium thickness is over 0.5 mm. If yes, and this is the superficial calcification, we have to use the lithoplasty balloon. It's available in US, but it's not available in Vietnam. if this is the deep calcium, we can appreciate that the deep calcium is easy to dilate. So we use the balloon is enough for dilatation on the lesion. And we see the Asian Pacific Society of Interventional Cardiology, they have some, I think it's similar approach to the European society. With the angiographic classification, we see a mile, we can do the balloon, just scoring balloon, a cutting balloon, NSC balloon is enough to dilate the lesion. And we see the intravascular imaging, for example, IVUS, I think is very important in the algorithm for the calcification like this. And we see it's similar to the Euro intervention. We have calcium arch, it's over 270 degrees. We try to use some rotational atherectomy, something like that. So with three algorithms from European, from American, from Asian country, we see the important role of the intravascular imaging, especially for the IVUS, to deal with the calcified lesion. So with the IVUS, in the severely calcified lesion, we have to do 3 steps. The first one, we have to do the IVUS before the PCI. Before the PCI, we do the IVUS. We can see the severity of the calcium, and also we see the plaque characteristic, and we plan the PCI surgery for the patient. And also we see the potential complication during PCI with the IVUS finding. And during PCI with the IVUS for the calcified lesion, heavy calcified lesion, we can we know that the IVUS the endpoint of the rotational atherectomy or the endpoint of the orbital atherectomy. And we also know that when we use the IVUS, we know that the lesion is prepared enough or not. And also we have the sand site selection for the lesion after we prepare the lesion. And finally, after sanding, we use IVUS to see the sand, is it optimized, optimal or not. And this is our experience. The pioneer of our experience is Professor Chung Quang Bình. In this section, we see the Professor Chung Quang Bình. We have some experience about the IVUS and rotaplator in our center. And in our center, IVUS penetration for the PCI is about 60% of PCI, and for the rota is almost 90% of rota. We try to use loss of IVUS in rotablation to reduce the complication, also to improve the stent optimization. And indication of the rota according to the IVUS in our center is that we have the moderately or severely calcified lesion over 180 degrees calcification of arch. And also we see, we heard about the indication from Dr. Wan Lee about the device could not rose, IVUS, a catheter could not rose, a balloon could not rose. That's a good point to try to do the rotablation. And also the cocktail in our center, we sometimes we don't have the rotaclide lubricant to do the rotablation. So we have the cocktail 5,000 heparin and 5 milligram NTG, and in the 500 saline. And guide for the rota, because in our center we only have the rotablation, we don't have the orbital, we don't have the lithotripsy. So the guiding for catheter for the rotablation, we use 7 French. On most of case 6 French or 7 French, but on most case with 7 French. And birth size we choose it's the birth to the artery ratio is about 0.5. 0.5 is mean that the vessel is about 3 mm. We choose the birth size is about 1.5 if we don't use IVUS in the rota. But if we use the IVUS and the cross the lesion easily, we measurement the IVUS by the IVUS, the minimal lumen diameter at the calcified lesion with plus 0.25 mm to choose the birth size for the rotablation. And in Vietnam, we have the birth size is about 125 to 2 mm for the calcified lesion. We choose that. And how to bring the bird to the platform, which you use a dynamic mode. And how about the speed in our center? use with a small burr, we use high speed 180,000 to 200,000 RPM, and with a bigger burr, we use a speed about 160,000 RPM. And the endpoint of the rota with the IVUS, we see if we have the napkin ring, we can find out some crackles in the napkin ring. This is the endpoint of the rota with the calcium napkin ring. But with the calcium nodal or something like that, we have to see the lumen, is it big enough before standing. And post rota, we usually use a cutting balloon or scoring balloon. We prefer scoring or cutting balloon than the NC balloon. And this is we can appreciate that this is the in vitro burr behavior with a lot with speed. We see that with a high speed, the burr is more stable, but with lower speed, we see here the burr is more unstable, and it touch into the vessel wall, into the wall more, and maybe we make the damage more. It looks like the orbital atherectomy with the burr with a low speed. And for example, we have some case here. The first one, we have the patient with unstable angina. We see the CTO in the RCA. We have the collateral from the circumflex to the RCA, and we have the severe calcification in the mid LED, and we have some aneurysm in this. And you see here, this is the 7-frame guiding catheter, and we try to use an IVUS catheter, but IVUS, you see here, the IVUS catheter cannot cross the lesion. Yeah, you see here, the IVUS catheter cannot cross. So that's the point we have to try to do the rota. This is 1.5 because micro catheter cross a lesion, so we try to use the 1.5 burr first. You see here the calcified, heavily calcified lesion in the mid LED. And this is the IVUS post rota. You see here the Y bias. When we use the IVUS for the rotation, or orbital atherectomy, we see the Y bias. This is the Y bias. It touches into the vessel wall in this side, and you see that the IVUS split into a more distal a little bit, and you see some vessel damage a little bit in 12 o'clock, because even this is not so calcified, but the IVUS catheter touch, the burr touch into this vessel. We have some vessel injury here, and we see the effectiveness of the rotablation. Yeah, and in this side, we see the calcified here, but the Y bias is not touched into the calcium, so we cannot see any reverberation in this calcium. So it means that in this side, the rotablation is not effectiveness. And this here, we see the Y bias here. The Y bias touch the calcium here, so I think this side, we have some reverberation. It's small reverberation, but I think it's enough. Yeah, this is Y bias. I think it's good for rota, but this is a big vessel, very big vessel. So I think the 1.5 burr cannot touch the calcium. And this is the lesion size. You see that? Of course, I'm sorry. Yeah, in this view, you can see the IVUS. This is aneurysm in the in 9 to 10 o'clock, and you see the IVUS. Here we see the rotablation touch the calcium and make some reverberation in behind. So this is the effect of the rotablation by IVUS finding. I think it's a very good picture for to see the IVUS, to see the rotablation effectiveness by the IVUS imaging. Yeah, you see here, and this is, you see here, the reverberation in the 10 o'clock. It means that the rotabur touch into this side of the vessel. Yeah, so we have some, oh, I'm sorry, it jumped. So after that, we use a balloon, 3-hour balloon NC, and you see we can appreciate that in the distal, in the mid LED, we have some vessel injury because the rotabur touch into the vessel. You know that even this is not calcified lesion, but sometimes the rotablation can make some injury in the vessel. And this is the final with the standing, the trio synergy stand, and yeah, and this is the Leftman. We see the standby lap position after standing, but after that we use a balloon, NC balloon, 4 balloon, and make the stand in the Leftman. Pull expanded into the vessel wall, into the Leftman. Yeah, you see that. Yeah, the stand now is full opposed to the vessel, to the Leftman. So before the PCI, we see that the LDD significant lesion and severe calcification, and we have some aneurysm. But after that, the aneurysm, I think, it disappeared a little bit, and we see the normal LAD right now. And the second case, we have the RCA. This patient came to the hospital because of unstable angina. In the left-hand side, you can appreciate that we have some haziness in the middle RCA here, and this is eccentric lesion. We don't know that this is the thrombosis or this is the calcification. So we check the IVUS. This is the IVUS. We see the some calcification from 9 o'clock to the 2 o'clock. This is superficial calcification. And we see more at the lesion. Yeah, we see here, this is the calcified nodule. This is a calcified nodule, small calcified nodule is protruding into the vessel. Yeah, this is calcified nodule. And we see more, the second calcified nodule come in. Yeah, you see the big calcified nodule here. We see here. Yeah, calcified nodule from the 9 o'clock to the 12 o'clock. You can see again. Yeah, you can see calcified nodule here. Yeah. So because this is the calcified nodule, we try to use the rotablation for this patient. This is the IVUS after the 2-hour rotablation with 160,000 RPM. This is the IVUS finding after rotablation. We try to use 4 times run of the rota 2.0. And in the right-hand side, you see that the rotablation touch into the calcified nodule. Yeah, you see in the both sides, and we make at the beginning it's flattened, but after the rotablation for the calcified nodule, we see the arch in the calcified nodule like this. And because we this lumen vessel is not big enough for standing, we try to make the bigger lumen by reduce the speed of the rotablation. So this is the 140,000 RPM. We reduce the speed of rotablation a little bit, and we can you can appreciate that in the left-hand side and right-hand side, the arch of the calcium at the calcified nodule now is bigger than the higher speed. Yeah, you can appreciate here. We see the bigger arch. It means that the effectiveness on the calcified nodule in the RCA. And you can see that at the beginning, before the rotablation, you see the calcified nodule in the RCA like this. But in the right-hand side, we can see that after the rotablation, we have the arch, the rotablation touch into the vessel wall. We have some reverberation beyond the calcified nodule, and the small arc of the calcified nodule here with the higher speed 160,000. And you see in the left hand side with the high speed 160,000, but when we reduce the speed 140,000, we make a bigger arc. I think in the right hand side, the RCA lumen diameter, I think, is big enough for stenting right now. At the beginning with the high speed, I think it's still small lumen diameter. And sometimes if the left hand side with high speed, if we don't make the good debulking for the calcified nodule, if we put the stent, sometimes we have the vessel rupture at the opposite side of the calcified nodule. So this is the case number 3. This is Leftman classification. In the left hand side, you can see the Leftman bifurcation, and just in the distal Leftman by the angle, we see some haziness in the distal, and in the TIMI view, we see severe lesion in the distal Leftman, and also we have the significant lesion and also severe calcification from the Leftman to the proximal LAD. And this is the IVUS finding for the Leftman LAD pullback. We see in the middle of the LAD, we see the eccentric plaque with the mixed plaque from fabric and also some fatty plaque here. In the proximal LAD, we have the moderate calcification, superficial calcification from the 9 o'clock to the 2 o'clock, but the lumen diameter is big enough. But in the distal Leftman, you see in the 1 o'clock, this is the distal Leftman. We see the this is a heavily calcified lesion in the distal Leftman. You see that, and this is the circumflex pullback. At 9 o'clock, we see the LAD wire, and we have opposite to the LD ostium, we have the severe calcification in the opposite sides of the LD ostium. This is the characteristic of the bifurcation, that sometimes we have the carina shift if we put the stent from the circumflex, if we choose the two-stent technique. And because of heavily calcification in the Leftman distal, so we try to use the rotablation for this size. This is 1.75 burr for the both side LAD and also the circumflex. And this is the final. We final with the decay crust, because this patient is quite stable. We do the decay crust for this patient. This is the final result of the patient. And the final case, and this is the case with Leftman disease, also the CTO in the RCA. We can appreciate that the Leftman disease diffuse to the circumflex, and the circumflex quite big here, and LAD diffuse lesion from the ostium to the middle LAD. And we also see the heavy calcification in the left coronary angiogram. And this is the RCA. RCA, we see the total occlusion CTO in the RCA. And for the safety reason, we try to do the PCI for the RCA first. And this is the final result of the RCA. Yeah, this is the RCA final.
Enough.
Yeah, I think it's good enough.
Yes.
Yeah, in the distal RCA, I think it's underfilled for the long time of the CTO, so we don't touch in the distal RCA. We just touch the middle from the proximal to the middle RCA. And after that, after 1 week later, we try to do the PCI for the Leftman disease. You know that heavy calcification. In the right hand side, we cross the Y, but the IVUS catheter, you see that some very tricky resistance, and IVUS catheter cannot cross the heavy calcified lesion in the LAD. And because of IVUS could not cross the LAD lesion, we try to use the rotor ablation for the LAD. This is the first run for the rotor for the LAD, but heavy calcification and the rotor burr cannot cross the target lesion because this is a position of the IVUS tip cannot cross the lesion. So the target lesion should be here. And after many times of the rotor ablation, finally we cross the lesion in the LAD. And we run IVUS again because we avoid to damage the unnecessary rotor ablation position. So we try to IVUS again. You see that the IVUS catheter stuck here, still stuck in the middle of the LAD. So we have to do the rotor run for the second time for the LAD at the position that IVUS could not roll the middle LAD. Then after that, we learn about the bifurcation, that when you have the severe calcification in the bifurcation, normally we have to do the rotor ablation for the both sides, both branch of the bifurcation for the optimal results. So this is the rotor ablation for circumflex. At the beginning, if the rotor ablation cannot cross on the middle of circumflex here, but finally it crosses a lesion here. So this is the beginning of the procedure. We have the diffuse lesion from the Leftman to the LAD and also the circumflex. But this is the final lesion, final result of the PCI on this patient. Of course, this patient refused cabinet surgery. So for conclusion, I think the IVUS is a very important device in PCI for heavily calcified coronary lesions. And IVUS help us to determine the strategy for heavily calcification, also to prevent the complication during the PCI by check the IVUS. While by us also we can check the plaque characteristic before we do the procedure. And also the IVUS help us to optimize stenting results. So that's in my presentation. Thank you very much for your attention.
Yes. Well.
Well, I think this time, Dr. Gautam Kumar, you can control the discussion.
Yes, that was a very complicated case that you showed. Now, actually, not just a complicated case, complicated 4 cases. And I think that was extremely difficult and great demonstration. Now, I had a question for you. Now, in terms of doing low speed rotational atherectomy, what is the lowest speed that you have gone to?
For the bigger burr, the lowest is 140,000. 140,000, the lowest one. Okay. Yeah, because we at the beginning we try to do the rotor ablation with a higher speed when we want to cross the lesion with the rotor burr. But after we cross the lesion, we usually will reduce the speed a little bit to get the big debulking, to prepare the lesion. So in the same case, at the beginning, we usually get a higher speed, maybe 180,000 or 200,000 to cross the lesion first, and after that we reduce the pace. And the lowest one is 140,000. Yeah.
Excellent.
I would like to ask one question. Yes.
Please.
Yes. because in the second case, the complex case, the second case, you see it's the angle, it is the CVS classification in the mid LAD. And the toxicity, very toxicity, about 70 on 70, 80 degree at the angle. So when we use the rotor Y, it's a bias on the IVUS. You see that very, very clearly. Why? You choose the big rotor 1.5 millimeter for the rotor ablation, because it's easy to make the perforation or perforation in this case like this. And as you when some experience when the Y bias like this. Yes, thank you. Because when we use the rotation in the bias, Y bias, we must use the small rotor 1.25. First, after that, you 1.5. Yes.
Because in this case, when we check the IVUS at the beginning, you see here the IVUS.
LED, not the
LED. The first case or second case?
Second case.
This is the second case.
Yes, second
maybe
case.
The third case.
Maybe third case. I'm not sure.
Yeah, this is third case. Yeah, you see that by the IVUS, you see here. By the IVUS finding, we can choose the burr size by the IVUS finding. And this is measurement. We see here the minimal lumen diameter at the calcium plaque here is about 1.5, because we know that IVUS catheter is about 1 mm. I think this is about 1.5, 1.6 mm. So normally we measure this diameter, and we plus 0.25 mm, and we that the burr size diameter for the rotor ablation. In this case, we choose 175 at the beginning, burr for this case. And sometimes this case we can try the 2.0 burr, but in Vietnam 2.0 burr is very rarely, so we cannot find the 2.0 burr in Vietnam. Only 175. So this is the IVUS guidance to choose the burr size when we do the rotational atherectomy. In this case, you see that IVUS catheter on 1 mm. I think these are 1.5, 1.6 mm, and we choose a 175. I think is enough for this case.
Yeah. Okay. I saw one question from the audience, comment from audience, Dr. Ngô Minh Hùng from the General Hospital to ask the panelists that in PROTECT 1, PROTECT 2 trial, the result it failed to use mechanical circulatory support. Why? In this case, in some case, severe case, we can still use the mechanical device support. Yes, you see the question from the audience. Dr. Ngô Minh Hùng, yes, can you share the experience and some experience in this case like this? Yes.
Yeah, I answered that question on the Q&A. So basically in PROTECT 2, just to remind everybody, that was a randomized trial in high-risk PCI of patients to both IBP versus Impeller 2.5 specifically. The trial was statistically equivalent at 30 days, but at 90 days, there was a favor towards Impeller 2.5 direction. I think it was like 50% versus 40% or something. In outcomes. So it was a close trial. It is possible to do IBP. I think the PROTECT 2 inclusion criteria was too large, and sometimes they just did low EF patients. I think for us, really, we find that we tend to only use the Impeller as support when you get to the extreme side of the inclusion criteria for Protect 2. So I will tend to not use it unless I have multiple criteria for Protect 2 present in the same patient. Like they have low EF, they have last remaining vessel, just like the case that was shared earlier. And it's also important to remember that the current impeller is the impeller CP, which can get up to 3.5, you know, and sometimes even 4 liters a minute in patients versus what they use in the 2.5. And there is no question for us that in high-risk patients who are unstable, the impeller patients are definitely more stable than the IABP patients. So whatever the trial data shows, it's definitely better. And now we do a lot of TAVR here. We use a lot of large bore access. So our experience with managing large bore 14 French sheaths is a lot better. And so our hemostasis and bleeding risk is much lower than it used to be before. And nowadays, when we use impeller CP as well, we use single access technique where we put the guide through the impeller sheath as well for the PCI. So there's only one access, which also tends to help things. So, you know, those are the things that have happened since the Protect 2 trial. And this is why we still like impeller. Dr. Kumar, do you have anything to add to that? Or?
No, actually, there's been a lot of advances, as you have described, with the impeller. We've become more facile with large sheets, especially with our structural heart program. There is an ongoing Protect 4 study at this point in time that may shed some light into complex PCI as to whether the impeller support may be helpful or not. But that is an ongoing trial. I think we are running about 20 minutes behind. So in the interest of time, if it is okay with the panel, I will also go ahead and introduce the next speaker. The next speaker is actually my colleague and a very good friend, Dr. Rajesh Sachdev, who is actually my colleague at the Atlanta VA Medical Center. He's a professor of medicine here, and he has been a great partner and friend for me for several years, and has extensive publications in complex PCI, FFR, coronary artery disease, and it is a great pleasure for me to introduce him, Dr. Sachdev. You may be on mute because we cannot hear you yet. Ah, there you are.
Okay. Can you hear me?
Yes.
Good. Good morning, and thank you for a great introduction, Gautam. I thank the organizing committee for Vietnamese, the Society for Interventional Cardiology, Dr. Wen, Dr. Lee, for this opportunity to present in such a prestigious forum. I think I started with. Okay. I'm going to present about shockwaves through the heart, the role of IVL in calcified coronary artery disease. So far, it has been a great presentations. Some of the material which I'm going to present, those slides may be a duplicate. Some of the previous speakers have already touched on this part. So the fibrocalcific disease is mostly seen in stable coronary artery disease.
I am sorry. I'm sorry. Look like your presentation not full in screen. The technician.
We are only seeing half the screen.
Yeah.
The left half of the screen is what we are seing. So maybe you can
share again. Share screen again.
Reshare. Yeah.
You might be sharing on a second screen if you.
Okay. Ah, beautiful.
Yeah.
Beautiful. Yeah.
So let me go to this again. Are you able to see the?
Again.
No, it's half the screen again.
Okay. All right. No worries.
Maybe you can just run it from this screen. Yes, just run it from here.
It's okay.
Okay. I can. there's a possibility the movies may not play. Okay. All right. There are two different types of calcification. One is the intimal, the other one is a medial calcification. Intimal calcification mainly involves the coronary arteries, and the medial calcification usually involves the larger vessels, especially aorta and peripheral vessels, and is seen in patients with end-stage renal disease. As far as intimal calcification is concerned, the oxidative stress leads to inflammation, and the smooth muscle cells turns into osteoblast cells and leads to deposition of calcium. There is also macrophages, which are supposed to play as osteoclast cells, and there is a downregulation of that, leading to further calcification. We all know that PCI of heavily calcified lesion is associated with procedural complications and or related adverse events. When a balloon is inflated in a calcified lesion, and there is a possibility of dissection or perforation, especially when you go on high pressures. Further calcified lesion impedes the stent delivery, and even if you're able to deliver the stent, there is a possibility that stent may not expand, which can further result in increase in ischemic events. So the limitations with the balloon-based therapies are that high pressure balloons preferentially expand away from the calcium, having limited effect on eccentric calcium. High pressure inflations are predisposed to major dissection and perforation, often at the interface between the calcium and healthy tissue. And balloons are typically unable to modify deep or thick calcium. So what are the modalities which are available in today's era? Atherectomy is the main sort of stay, which includes rotational atherectomy, and we heard a lot about it. Along with that is orbital atherectomy. Now, these techniques or the therapies require dedicated wires. There is thermal injury, which promotes platelet activation, leading to increased risk of clotting, which can result in distal embolization, resulting in slow flow or low reflow, which can result in periprocedural myocardial infarction. Now, ablation is contact dependent. It's unable to modify calcium in a larger lumens and a deeper calcium. It's unable to protect the side branch with a second guide wire. Now, the potential is also there to transect the wire and lead to large dissections and perforation, especially in a tortuous anatomy. Now, lithotripsy has been available in the extracorporeal lithotripsy in kidneys for past 3 decades. We have used this lithotripsy techniques for breaking up the kidney stones. The intravascular lithotripsy is a miniature and arrayed lithotripsy emitters for localized lithotripsy of the intravascular or the coronary arteries. The difference between the extracorporeal lithotripsy versus the intravascular lithotripsy is that the energy profile is really low, as shown in the graph. The energy which is sort of produced in terms of pressure, measured in pressure, is about almost 100 atmospheres, and the energy or the pressure which is produced in the intravascular lithotripsy is somewhere around 50 atmospheres. So what are the potential opportunities for coronary intravascular lithotripsy? There is no requirement for a specialized wire. Shock waves pass through the plaque and vessel walls, enabling modification of the deep calcium, and disrupted calcium remains in the vessel wall, thereby reducing the risk of distal embolization. Now, lithotripsy allows calcium modification to be performed at low balloon pressures, thereby avoiding the risk associated with high pressure inflations. It also enables one to protect the side branch with the second guide wire. The components of IVUS include a generator, a connector cable, a catheter, which has a balloon. A balloon is about 12 millimeters, and it has 2 emitters, and the balloon sizes are 2.5 to 4 millimeters, and it is capable to give 80 impulses. So the mechanism of shock wave is various ways it works through. As I said, there is an initial rise in pressure, which is in 1 microsecond. The pressure goes up to 50 atmospheres. That is called the shock wave. And then in next couple of microseconds, there is a negative pressure, which is also called the tensile phase. So the shock wave causes a squeezing, which can result in the circumferential force on the calcium, leading to tensile and shear stress at the proximal and the distal ends, leading to fracturing. The second force, which acts as a cavitation force, which is at the sort of surface of the calcium, and this starts when there is a sort of a negative pressure and the negative jets are created, and that also leads to fracturing. The calcium which is there in the arteries has imperfections, so all these forces, when they're acting, they causes fractures by like fatigue fractures or stress fractures. And lastly, the shear stress which is there is called the circulation force. While the calcium is moving in one direction, the energy is reflected from the distal or the farther part of calcium, and then the more proximal part starts moving in the other direction, while the distal part is still moving in the same direction, which creates more fractures. So this is a video which shows how this IVL works in situ.
The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. When the waves impact the calcium at nearly 50 atmospheres, the vessel becomes more compliant.
So this electric energy is delivered to the emitter, initiating a steam bubble which expands and collapses, creating a sonic pressure wave. And this sort of a pressure wave then impacts the vessel wall and the calcium in the vessel wall at the balloon vessel interface. This is the video which shows that the calcium-like material is on top of the balloon, and when the IVL is initiated, how a harder calcium-like material can be broken into small particles and break apart. On the other hand, the softer tissue on the right-hand side, the energy is able to dissipate through the softer tissue, resulting in no damage to the tissue. This is the OCT showing a 360-degree calcium and a OCT after the IVL treatment, leading to both longitudinal as well as circumferential cracks. And this sort of can result in optimal expansion when the stent is deployed. Now, this is a pre-IVL picture of calcium and a micro OCT showing that when a IVL is applied to this calcium, can result in microfractures, which could be longitudinal or circumferential. And this is on the right-hand side is a histological picture of a microfracture shown over here and here, and same microfracture is on a micro CT. So there have been several studies showing the efficacy of IVL. The first study was a Disrupt CAD-1 study. It was a safety and feasibility trial. Second was a Disrupt CAD-2 study, which was a safety and effectiveness trial. And then the third study was a Disrupt CAD-3 study, which led to the approval of IVL in US. And I will be talking a little more detail about this particular study. So what all these studies have shown is consistent procedural success and a low MACE rate. So talking in particular CAD-3 study, majority of these patients had class 2 and class 3 angina. There were some patients with even asymptomatic ischemia which were enrolled. All sorts of vessels were involved. The calcified length was about 48 millimeters, and all these patients have severe calcium. The total procedure time was about 53 minutes, and there were about 1.2 catheters used on an average, and the stent was delivered in 99% of the patients. The procedure was successful in terms of device crossing in 96% of the patients, and procedure success was in about 92% of the patients, with minimal complications post-IVL, mainly because of dissection, which were tacked up with the stents. So when you look at the MACE rate, the MACE rate was about 7% in hospital and about 8% at 30 days, and mostly it's driven by myocardial infarction, which is as a result of peri-procedure myocardial infarction mainly. So there was another arm in this trial, which was the OCT arm, where they enrolled about 100 patients. They had undergone a pre-procedure OCT, a OCT after the IVL, and a OCT after the stent. And the findings were quite interesting. As you can see, the maximum calcium angle was 293, and the maximum calcium thickness was about 1 millimeter. And after the IVL treatment and stent placement, the minimal stent area achieved was 6.5 millimeters square, which is pretty good. So the conclusion of this study was the Disrupt CAD-3 trial achieved both primary safety and effectiveness endpoints, and coronary IVL prior to DS was well tolerated with a low rate of major peri-procedural complications, and OCT demonstrated longitudinal circumfracture calcium fractures, leading to increased vessel compliance and large post-procedure MSA with excellent stent expansion. This is a case from our cath lab. This is a patient with coronary artery disease who presented with angina, has a moderate disease in the mid-LAD. He underwent FFR assessment. The RFR was 0.83, and the FFR was 0.78. The IVUS did not cross the stenosis. He underwent a rotablation. After the rotablation, IVUS was again attempted. It was again a no cross, but you can see there is at least a 180-degree calcium, which is there. So IVL balloon was used, a 2.5 by 12 millimeter IVL balloon was used, and I think about 50 impulses was given. And after that, you can see that this leads to fractures over here at 12 o'clock position, and you can see as it moves forward, there is a fracture even at 3 o'clock position right here. This was followed by a placement of a balloon, a chapter balloon, and followed by a stent, and with the good expansion and apposition. IVL has been used in multiple other lesions besides what have been studied. including left main, large vessels, bifurcation lesions, osteal and tortuous lesions. So that brings us to a question. What are the patients where we need to use OCT? And some of this has been addressed in previous talks by Dr. Lee and Dr. Kumar. And I will go to the algorithm and I will just walk you through this algorithm. The best candidate which can be benefited from IVL is a patient who has angiographic assessment and shows that there is calcium. Now, if this patient you cannot cross, it doesn't make to put a IVL balloon there, so you want to go to rotational atherectomy or laser or orbital atherectomy. But if you're able to do a imaging, OCT is preferred, but you can use the IVUS. And on OCT or IVUS, you're looking at the arc of the calcium. If arc of the calcium is less than 180, you can use the specialty balloons to actually dilate this. And after pre-dilatation or adequate pre-dilatation, you can do the stenting. Now, if there is nodal calcium, the preferred way to treat this is rotational atherectomy, as shown by one of the previous presenters. Now, if this is a greater than 180 degree calcium, you want to further assess the thickness of the calcium. If the calcium is thicker than 0.5 millimeter, IVL is the better modality to treat this kind of a calcified lesion. Now, if the calcium is less than 0.5 millimeter, I think you want to look at the length of the calcium. If it's greater than 5 millimeter, they will benefit from IVL treatment. We also believe that these patients can be treated in a different way, especially the ones where you are unable to really cross the stenosis. I talked about the primary IVL treatment, which was studied in Disrupt CAD3 trial, but there is a subgroup of patients where you're not able to cross with a balloon or a imaging catheter. And I think this so-called secondary or rota shock treatment could be beneficial. This could be applied as a rescue treatment if there is an inability to dilate the vessel with a conventional balloon or rotational atherectomy. You can apply a shock wave to that, or it can be used as a more of an elective that you can actually do a rotational atherectomy with a small burr like 1.5 burr and followed by IVL, and that will give you a radial access to the smaller sheath size with the potential decrease in embolization. Thank you.
Xin mời Dr. Nghĩa, you are moderator.
Yeah, thank you. I would like to ask you one question, Doctor. Because I had one case, a patient is 75-year-old. 10 years ago, 5 years ago, when we do angiogram, the patient had the mid-LAD severe with severe calcification in mid-LAD. So I do the angiogram, we do the rotaplator with 1.5. 1.5. After that, we deploy the stent 3.5, 20. But after the 3.5, 20, we use the NC balloon. I go up to the 20 millimeter atmosphere. We cannot open. Not fully expansion. I go to 24. So, after that, the patient discharged from my hospital. And 2 years later, the patient come back with the chest pain. I do angiogram again. We see the restenosis in the mid-LAD. I only because we already deployed stent already, so we only did the NC balloon to reopen only. But now the weight in the mid stent is still have. So now this case we can use the lithotripsy. It's difficult for me to treat the patient. I will ask a question, and this patient can use it is the best option for the patient. Thank you.
So I'll give you an example. Recently, when IVL was approved, we had a patient that had come with angina, is unstable angina, had known coronary artery disease with multiple layers of stent in the right coronary artery. And there was a focal instant restenosis. And we thought we could just balloon it and dilate it. And we ballooned it. It looked like the balloon was expanded. It was more like a napkin ring kind of a stenosis. Believe me, the FFR was positive. It was a napkin ring kind of stenosis. We ballooned, balloon looks expanded, and I placed a stent. And when I placed the stent did not expand it completely in the middle. And you know, I used a NC balloon, tried to post dilate, went to 30 atmospheres, it won't yield. So at that time, IVL was approved for periphery. It was not approved for coronary. So we actually had him come back, and we used the peripheral IVL, a 4O balloon in that patient. And you know, with the 20 treatments, that area was opened up. And we used the high pressure NC balloon, and that artery looked beautiful after that. So I think there is a utility of this technology. And on the other hand, yes, there are other modalities also, like laser you could have used, but laser is not available in each and every hospital. There is a very limited penetration of laser. But I think IVL has much more promise. I think down the road, as it is utilized more and there is more and more trials, and there is a comparison of IVL with other sort of technologies like atherectomy, rota or orbital, I think there is going to be a lot more sort of usage of IVL. I think it's going to show that it has a promising career down the road.
Yeah, thank you.
So, Dr. Nghĩa, I think in your case, we have a restenosis, instant restenosis. That time, maybe we use IVUS to know the mechanism of the restenosis. We have the hyperplasia of the intimal, or we have a new atherosclerosis at the inside the stent. And when we know the mechanism, we can choose the way to treat your patient.
Thank you.
Yes, and it has been very well reported that the hyperplasia or neuroatherosclerosis, which happens inside the stent, can be calcified. And it has been already published that you can develop a 360-degree of calcium in this hyperplastic tissue.
Yeah, thank you. At that time, the patient with intense restenosis, the IVUS machine in my cath lab is this out of order, so I cannot record it. inside the stent, inside. But when I go up the NC balloon 24 to 24 atmosphere, the wet is persistent, still persistent, not disappear. So I think napkin ring in this patient is very thick. I think that's I would like to ask the doctor one question about IVN. It is better for the luminal, superficial, or median calcification or not? Is the benefits in the superficial calcification or the median calcification? Yes.
In both. In both. Yeah. So in the periphery, it is used, and usually the calcification of peripheral arteries is a medial calcification when you're dealing with iliacs, and there is a combination, I should say, both intimal as well as medial calcification, and IVL is the treatment that actually works on both.
Yeah, thank you.
Dr. Nghĩa, Dr. Đinh Đức Huy, right hand.
Right hand, yeah, okay.
Sorry, there was a very good question in the Q&A. Somebody asked the question: when you have immediate under expansion of a DES, can you use an IVL immediately? Will it cause the polymer to damage? And does that cause your DES to be less effective? The company has some data that shows that the polymer is damaged by the IVL. So some people would recommend that you bring them back. But obviously, if the stent regret is very severe, you may be taking a risk by not fixing it straight away. So sometimes we have done it straight away before. We did some experiments at the University of Arizona where we did in vitro expansion of both the Zions and the Resolute. And then we subjected the stents to 80 pulses. And then we studied them under an electron microscope. And there was no polymer damage, contrary to what the company said. So maybe it's okay. The other way to fix the problem, if you are worried about it, obviously, if you have a drug-coated balloon, you use a drug-coated balloon after you have done that to the stent, or you can put another new drug-eluting stent inside the first drug-eluting stent. Nobody knows for sure, and it's never been studied formally before.
Yeah.
Sorry.
And
Dr.
that was a fantastic question, and thank you for answering that. Dr. Lee. In our case, we actually waited for about 3 weeks. So majority of the drug is eluted before we actually brought this patient back for the same reason.
Dr. Rajesh, can I ask, is there any factors, angiographic or imaging that can predict successful or failure of IVL procedure?
Not angiographic per se. You want to see fractures with the IVUS, and one thing you can see is the IVUS crosses through initially if you're not able to cross, that you have made some made some fractures, that's why you're able to cross. On the other hand, now if there is a dog boning in the balloon catheter, when you inflate it angiographically, when you're giving impulses and that dog boning goes away angiographically, then you can say that you have treated that lesion. Now, there is a good possibility, majority of the lesions you're doing, you may not see the dog boning. In a particular case where you're seeing that one particular area is not dilated and you start giving impulses because you're applying only 4 atmospheric pressure and that balloon opens up, you know that you have successfully treated that area. On the contrary, if the balloon was sort of expanded and you applied those impulses, you probably won't be able to say angiographically that you have actually adequately adequately treated that lesion or cause some fractures in that. So you have to study with either IVUS or OCT.
Yes, okay, thank you. Now I think I can move on the last presentation. Dr. Dũng.